it's surprising to see that when you search the net, the majority of the papers that you would get seem to be originating from India. So many from our teaching hospitals, so many from a private setup. So that just goes to show that Indian urologists are already using laser for stones and publishing data far more than the Western counterparts probably are. This particular comparison of holmium laser and pneumatic lithotripsy in the management of upper ureteric stones. We all know that lower ureteric stones, there's not much to choose. Whether you use a pneumatic lithoclast or you use a laser, it probably does not make a lot of difference. If you have the facility of a laser, please go ahead and use it. But between them, it's the upper ureteric stone where you would have to make a decision and choose the laser. So there's a better fragmentation with laser, 97% as compared to 86% with pneumatic lithoclast. Perforation of the ureter is less with laser lithotripsy. The need for auxiliary procedures, like a stone has slipped up and you would subsequently have to use a flexible scope to remove it or to give lithotripsy, is less if you're using laser. It's only 2% as compared to about 14% for using pneumatic lithoclast. And sepsis is obviously less, about 5% with laser and 11% with pneumatic lithoclast. A very similar study from Pakistan also looked at upper ureteric stones, holmium laser versus pneumatic lithoclast. They saw a few extra points. Stone migration they reported was 2 out of 50 in laser lithotripsy, whereas it was 8 out of 50 in pneumatic. Stent use, they haven't detailed on what exactly they used to decide whether a patient should have stent, but the results say that the number of patients who needed stents was less with a laser lithotripsy as compared to pneumatic. Obviously, if the number of perforations are higher, if you have had injury to the mucosa, you would probably like to keep in stents, and they might have contributed to the decision making. Residual fragments which have not cleared off immediately or which have flown back into the kidney in a pneumatic while using pneumatic lithoclast, which you expect might come down later on or which might require supplemental lithotripsy, you would probably have to keep a stent. The 4-week stone-free rate with laser was also better as compared to pneumatic lithoclast, and complication rates were also less. Ureteroscopic laser lithotripsy versus ballistic lithotripsy for the treatment of ureteric stones, a prospective study from PGI Chandigarh 2009. They concluded that we conclude that both laser and pneumatic energies are effective and safe for intracorporeal lithotripsy. Laser lithotripsy takes more time but provides earlier stone-free status. In this particular study, they assessed immediate clearance versus delayed clearance. The delayed clearance of fragments was approximately the same in both of them, but the immediate clearance was higher with a laser. So there is some variation in the final results in the different studies. Having compared ballistic lithotripsy with lasers, there are some studies which have compared upper ureteric stones which have been treated with ESWL versus laser lithotripsy. Now there are a lot of studies which try to show or which try to understand the fact whether ureteroscopy should be a procedure of choice in the upper ureteric stones or whether it should be ESWL. Apparently, the long-term stone clearance rate with both the procedures are not different. However, choosing a laser or a ureteroscopic clearance allows giving the patient immediate results with less morbidity. This particular study from BJU International has actually given the results in the form of efficiency quotient, and they say that laser lithotripsy has an efficiency quotient of 0.52 versus 0.39 for ESWL. And endoscopic lithotripsy with holmium laser is more effective than ESWL. Efficiency quotient is basically a result obtained from initial success rate, need for retreatment, need for auxiliary procedures to put together. And efficiency quotient was actually for the first time described by Ralph Kleiman. And it's used to compare various modalities, including the results of various lithotripsies, the result of any other procedure. So that's a good standard way of representing your results, which takes into account retreatment rate, complications, etc. altogether. Beyond studying flexible ureteroscopy, this is a particular Chinese study which talks about retrograde ureteroscopic treatment for upper ureteric stones. It's not a very descriptive study. The points and the way it has been written is not very much clear as far as the data is concerned. So while I'll not be able to give you much data, the final results which they have mentioned is a high post-operative stone-free rate is associated with the refined use of holmium laser lithotripsy, and rates of intraoperative and post-operative complications were 14.6% for the pneumatic group and 3.9% for the laser group, which is quite similar to the previously mentioned Indian studies. Now, while we know that we could use it for upper ureteric stones, is it fair to use laser for treating or breaking the stones during PCNL? PCNL is associated with a large stone bulk, and as you have seen, larger stones in the bladder can be well treated using higher wattage settings. So there are two studies which have tried to look at the use of laser in PCNL. The first one says that in our experience we found that holmium YAG laser and pneumatic lithoclast are both effective and safe lithotripters for percutaneous stone removal. More operating time was required for laser, more complications were encountered with a pneumatic lithoclast. The second study, one of the older studies, in which they had done 334 PCNLs and used the laser for breaking stones. They felt that 13 of those stones, which were very large staghorn stones, the use of laser was probably very tedious and time consuming, and so they needed to supplement it with pneumatic lithoclast. So friends, while this might look like 3.7% of patients might not be suitable, it also means that as big as 96% of patients can be well treated with a pneumatic with a laser lithotripsy. Even in PCNL you could break the stones with laser. The other advantage is that if you have access to a flexible nephroscope, it helps reduce the number of punctures. If you have a flexible nephroscope, you access stones in parallel calyces or stones which are difficult to access otherwise. You have a laser present, you could have a basket and you could remove stones. So obviously the presence of a laser helps reduce the complications and morbidities of PCNL by reducing the number of punctures that you would need to remove stones. Now applications in RIRS, that's well known. RIRS you could probably do only with flexible ureteroscopy with a laser, although there are some flexible scopes available, flexible probes available now for electrohydraulic system and for pneumatic also, but they are not yet very popular. Now the application of flexible ureteroscopy was first described in 1964, and an American company made the first scope which was passed up the ureter to impact a ureteral, to visualize an impacted stone. Flexible ureteroscope can be used for a lot of other things rather than calculus management, but since I am here to talk about stones, we should be talking about it. Now in 2008, one publication also from PGI Chandigarh said, as of now the true indications of flexible, and there is an urgent need for a randomized trial to compare its efficacy with ESWL and PCNL for renal and upper ureteric stones. Gentlemen, there are a lot of inventions and discoveries in medical science, but if you are managing stones, you will come across situations wherein you would feel that if I had a flexible scope, I would probably have managed this patient better. It's difficult to get series of such patients. They'll come up in your practice, a patient who might come and tell you that I can't come back for repeated lithotripsies. Whatever you do it for me once. Obviously, the chances of a clearance in one go with a flexible ureteroscopy is much higher as compared to attempting lithotripsy, where you cannot guarantee in any way that you would be able to clear his stone in one go. A lower calyceal calculus, a lot of studies have been done trying to prove whether PCNL is a better choice, whether lithotripsy is a better choice. Most people would agree that when it's less than 1 centimeter in size, ESWL is a fair choice. Beyond 1 centimeter, it depends on you whether you would like to go in for a PCNL, whether you would like to go in for a RIRS. Within a duration of 1 to 1.5 months, they had a renal pelvic stone. Now, if I were to give the patient ESWL, I would risk precipitating another attack of pancreatitis. So, flexible ureteroscopy, they gave me a safer option, and I was able to use a flexible in that case. The other situation is a patient who has got stones in multiple calyces, stones situated all over his kidney. So would it be fair to make so many punctures and try to remove them by PCNL? Is it fair to give a patient lithotripsy wherein you're shocking the kidney right from the upper pole to the lower pole? I think these would raise doubts in the minds of urologists.
But if you have a flexible ureteroscope, you can go ahead and pluck out, systematically remove all the stones from all the calyces one by one without causing much injury or harm to the patient. Obesity, although we do not see too many patients, but in the years to come we are expected to see more of these patients. We had a 120 kg elderly female. We put her on the lithotripsy table just to see whether we could be able to focus her, and very soon realized that she was covering up the shock head, she was covering up the whole ultrasound probe, and we had absolutely no scope for movement. Forget the fact that we could hardly see anything across that fat and localize the stone with the C-arm. So obviously flexible ureteroscopy was the choice for her. I wouldn't be very confident trying to do a PCNL on a 120 kgs patient putting her obese. This was an easier choice. Pregnancy is mentioned as one of the conditions wherein you could try a flexible ureteroscopy. I do not have any experience. I would probably prefer to put in a stent and leave it, but if somebody has done so for pregnancy, I would just like to know how the results have been. Patients on anticoagulant therapy, obviously. The other is portal hypertension. Portal hypertension, we had a patient. We know that portal hypertension can be associated with retrorenal varices. PCNL or lithotripsy might result in bleed from those retrorenal varices. So flexible ureteroscopy would be an easier choice. This particular patient had an ectopic kidney with a stone in the ectopic kidney, very difficult to visualize on X-ray KUB, even on IVU, and therefore very difficult to treat by lithotripsy and possibly also by PCNL. RIRS was a fair choice for him. There's some studies now trying to prove whether we could be using flexible ureteroscopy and laser for larger stones. This particular study from Singapore talks about stones of up to 2 cm in size, and this one from India, from Dr. Prabhakar, talks about removing a total stone bulk of 3.5 centimeters using flexible ureteroscopy. I spoke to him today personally, and he said that he managed to finish it off in one sitting and achieved 100% clearance, which is very commendable. So the limits of size actually seem to be changing, and you could probably go to much larger sizes and remove. You could treat stones in calyceal diverticulum. You could treat stones which have been resistant to ESWL, and in a Western study it appeared that a flexible ureteroscopy in their country was less expensive as compared to PCNL. However, it's not so in our center. I think flexible ureteroscopy would probably be more expensive. Lithotripsy resistant stones, they have been treated. Now I'll just finish off with what EAU says as far as stones are concerned. ESWL and PCNL are recommended primary treatment options for renal stones of less than 20 millimeters in size and more than 20 millimeters respectively. Flexible URS was stated as an effective treatment for ESWL refractory renal calculi. This was a grade A recommendation with reported stone free rates of 50 to 80%, while larger stones could also be treated successfully. They go on to say that because of poor results of ESWL for lower polar stones, flexible URS could become a reliable first line treatment for lower pole stones of less than 1.5 centimeter, and flexible ureteroscopy is also an option when ESWL might be contraindicated or ill advised, example patients on anticoagulant, obesity, pregnancy, etc. Thank you.